My name is Lucy Mays. I'm nursing faculty here at Morehead State University. My office is right upstairs. I also work with St. Clair Regional Medical Center and Family Medicine Express as a nurse practitioner. And so unfortunately, I see a lot of childhood obesity. So I'm very encouraged by the attendance at this conference and also by our nationally renowned speakers. I'm very pleased with what I'm hearing so far. So our next speaker is, let me put on my glasses, Dr. Chris Bolling. He completed his pediatric residency and chief residency at Cincinnati Children's Hospital Medical Center. He is certified by the American Board of Pediatricians. He is currently a pediatrician and partner at Pediatric Associates in Crestview Hill, Kentucky, and he's a volunteer associate professor of pediatrics in the Division of General and Community Pediatrics at the Cincinnati Children's Hospital Medical Center and the University of Cincinnati College of Medicine. Dr. Bolling serves as the chair for the American Academy of Pediatrics section on obesity and chair for the Kentucky chapter of the American Academy of Pediatrics Obesity Task Force. He is the former president of the Northern Kentucky Medical Society, the Cincinnati Pediatric Research Group Practice-Based Research Network, the Cincinnati Pediatric Society, and the medical staff of Cincinnati Children's Hospital. And after all those tongue twisters and all those wonderful credentials, here is Dr. Bolling.
Thank you. Thanks, Lucy. So as Ashley said in her talk, feel free to interrupt me at any point. What I'd like to kind of go over is a bunch of things today. These are just our objectives, which I hope you come out of here with some ideas for advocacy for pediatric obesity and treatment and prevention in your own life and own community is the goal. And I do have one disclosure. I think I have a bit of OCD, and one of the reasons I like obesity work is I like trying to bring order out of chaos, not chaos out of order, but order out of chaos. And I think obesity is really chaos. You know, I think as we go into a room with a patient or we meet somebody, we're like, how in the world am I ever going to figure all this out and make a dent in this huge problem? And sometimes, rightly so, we just sort of throw our hands up like, I can't fight against all this, and I just give up. So my message is pretty simple today. Don't give up. And small steps make a big difference when it comes to a huge, overwhelming problem like obesity in society. So there's really a need for community change. I am a fifth-generation Kentuckian, and we live right in the buckle of the obesity belt. You know, it's sort of the same zone of the country. This is, I'm sure, some things that you guys already have seen. These are obesity rates for adults, state by state, and we really have, you know, quite an epicenter in the southeast U.S., in Kentucky actually mimicking quite a bit what happens nationally, that the southeastern part of our state is the most severely affected. If we look at pediatric obesity, as was mentioned, we are right up there. Stephanie kind of made the mention, you know, our state motto, which is thank God for West Virginia. We also have, you know, our colleagues who struggle the same way that we do with rates of obesity. And it's really an overwhelming problem for us. And so it's easy to get discouraged. It's easy to get really disheartened by all of this. But we can make a difference. You know, why is it that it's our neighborhood? And I really get tired of hearing pejorative things about Kentucky, honestly. You know, it's because of this or it's because of that. It's because we, you know, I got actually smacked down once, and rightfully so, because I had someone from Estill County said to me, you know, we were talking about the perception of weight status, and I was kind of making these broad generalizations, like, oh, it's not as, you know, not as much of a stigma in certain populations and in areas where there's been a lot of hunger. It's more of an accepted term. And I really got smacked down, and like I say, rightfully so, because somebody said to me, you know, is what you're saying is that it's okay to be obese in certain areas and not in others? Because if that's the case, that's really wrong. We all want our kids to be healthy. It doesn't matter if you're white, black, Appalachian, Latino, rich, poor. We want our kids to be healthy. And that's an important thing for us to remember. This is not about value judgments on you don't care about your child's health, you don't care about this or that. We all care about having healthy kids, and it's really important to remember that. It really is about demographics, though. This is not as much an issue about white, black, Latin, Appalachian, as much as it is poverty. Our patients who suffer from poverty, and I was really glad, Lavendra, I brought it up about hunger, that these are the same populations, as we all know, that suffer from oral health issues, that suffer from hunger. So it's populations that tend to be African American, Appalachian, Latino that suffer a greater deal. But it's really not because we live in Kentucky or we live in the District of Columbia. It's because there's higher poverty rates that we deal with. And that's what really seems tightly linked with oral health indicators, obesity indicators, and overall health indicators. I think everybody's familiar with the socioecological model. Everybody has seen this before, right? Where we talk about, how do we really talk about health indicators? It's really easy. And, this is a talk on advocacy. So I'm going to bring in some of our state legislators into some stories that I have to tell. But, it's a really convenient thing for politicians to say, oh, you know what, this is about personal choice. If people wanted to be thin, they could be thin. That's the way it is. Well, it's really not, especially when we're talking about kids. I mean, when we're talking about weight management, absolutely, individual is a very important piece of it. But let's talk about this a little bit like almost from a smoking cessation perspective, because we know we've made a lot of progress with reducing smoking. Stopping smoking takes a very strong individual commitment to stop smoking. But it also takes families and friends who don't smoke around you and give you encouragement. And it takes organizational support to have, like the Share building here, a smoke-free building. A smoke-free workplace helps. It helps to have a community that also supports you in this, that has smoke-free restaurants, that has ways for you to interact with your provider who can help you stop smoking. And it also helps to have some public policy built around it, where actually there are excise taxes on cigarettes that price them out of adolescence range so kids don't get started smoking. I always laugh about smoking in particular as a full-time pediatrician like I am. Parents always have these big wide eyes when I'm talking with their fifth graders saying, remember, don't smoke. And parents are looking at me like, what are you talking about? They're fifth graders. I'm like, you know what? I took my first smoke from a cigarette in fifth grade behind Gary Whittle's house from down the street from where I went to grade school. So, it happens and it's nothing new. These are habits that start early, and they're habits that we need to talk about, and they're habits that are really supported by families, by communities, by schools. It's a team effort. So what kind of strategies can we build? What kind of strategies do we know really work around obesity prevention efforts? Well, it's the same ones that work around smoking efforts and other efforts at public health. We have to commit and to develop a plan that is a community action plan, often helps. Developing and spreading, as Ashley mentioned, a consistent message. We've tried a little bit on the state level. We have healthy numbers for Kentucky families. It's put out by Action for a Healthy Kentucky. There's a website. There are a couple videos if you ever hit it. But it's 5210 Healthy Numbers for Kentucky Families. And we propagate that out into child care facilities, et cetera. So I'm sure some of you have probably seen it. We just need more funds to get that message out. But a consistent message is important. You want to be assessing weight status and talking about obesity both inside the healthcare setting and outside the healthcare setting. I think if we are only preoccupied with our own healthcare setting, we send our patients out into a cruel world. It's not going to be met with a lot of success if they get no reinforcement or a constant barrage working against what we're saying inside the clinic. Developing healthy weight plans is helpful. Building capacity to meet community needs across sectors is important. Making sure that our communities have the resources they need to actually do something. And improving environment is really a big piece of this when we talk about community advocacy. So when we're talking about advocacy and advocacy opportunities, just be kind of thinking about these 6 strategies. First things first, it's good to have some good content to work with if you're going to be an effective advocate. You can't be like coming up with stuff sort of on your own. You want to make sure that you're using tested and true things that are really based in science. You want to know what works, what's supported by research. It's also important to know what's achievable. And you also want to know what other communities have done. So you can kind of go to community members, to legislators, to say, hey, this is what West Virginia is doing. This is what Arkansas has done. This is what Aberdeen, Ohio has done. So you can kind of go back and say, you know what? This is in our wheelhouse. We can actually do this. And it's also to know what strengths your community has. You don't want to try to have to reinvent the wheel for everything. You want to really take advantage of what you already have built in. And you want to know what your community's weaknesses are. So why is environment important? It's where we all interact. We have this is a picture, obviously, of a subdivision where a bunch of houses are connected by cul-de-sacs. It's sort of the picture of the American dream. But if you notice, there's really no other place to walk except to other houses. Can anybody identify this road? Anybody know this road? Any fellow Kentuckians know this road? This is Southern Highway in Louisville. And so you take your life in your own hands if you try to walk from point A to point B along Southern. Preston Highway. You really are going to be in danger if you try to walk along this road. So what we're trying to do is, from an environmental perspective, is trying to get communities that are more walkable. That means something very different for Moorhead than it does for suburban Louisville. It means something different from Moorhead from rural Rowan County. So it's something different depending on your community. We know, we've talked about this, I won't drill on it too much, is we know that there are a lot of behaviors that are good targets for community advocacy. We know that kids are not eating fruits and vegetables, they're drinking too much soda, so there's some good targets. We know the kids are undernourished in a lot of ways. They're hungry. They are the same age, at about 5 to 8 years of age, when obesity really starts becoming a problem. And Ashley and I have Ashley kind of mentioned it earlier, that it's earlier and earlier. But we've historically seen kids really fall off the chart in this 5 to 8 year range. These are actually individual lines, average levels of these main nutrients. And at about the same time that kids are becoming heavier, they also are really dropping in a lot of these nutrients. So not only are kids, I would say they're overfed, but they're undernourished at this age. So it's a problem not only of getting enough food, they're not getting the right kinds of foods. I won't beat a dead horse. We know the issue with sweet drinks. Kids drink twice as much soda as milk currently. A 12 to 19-year-old boy who drinks soda consumes an average of 81 gallons per year. Girls who drink an average of 61 gallons per year. A 12-ounce can of soda contains 11 teaspoons of sugar. That's also an Ale 8-1, contains that much. A person who drinks one 12-ounce can will gain 10 to 15 pounds if everything else stays the same. So that's just one intervention. And it's also about sweet tea, as we mentioned, sports drinks, lemonade, 100% juice. Controversial areas certainly are diet drinks and flavored milk. They're sort of, probably second best choice to water and low-fat milk. Physical activity patterns. We know physical activity is under assault on the school level. We know that screen time is up. This stat from Nielsen always shocks me, that kids between the ages of 2 and 5 spend on average 32 hours a week watching television. That's changing a little bit. It's shifting more, just since 2010, it's shifting more toward tablets and smartphones, but rates are unbelievable. So another opportunity area. This is Northern Kentucky specific data. This is the dark orange represents percentage of schools that require physical activity, and then the light orange indicates that it's optional. Well, I can tell you for juniors and seniors, if it's optional, it ain't happening. But it really drops down as kids go through older ages. They lose physical activity, so another opportunity. We work against the perception of safety in a lot of communities. I mean, it's very, very true that we have a lot of our patients that live in dangerous neighborhoods, that you can't really just say, go out and be more active. You have to help them problem solve it. But I would also say that for the majority of patients, there are a lot of patients who live in very safe communities. If you look at the numbers of when I was growing up versus today, the murder rate actually peaked in 1980 and violent crime rates peaked in 1991. Current rates are close to the 1950s and 60s. So, could the difference be Nancy Grace? It's very possible. She will have you convinced that the minute you walk out of your house, you're going to get abducted. I think a lot of it is we're battling a little bit of perception. Certainly it's different from neighborhood to neighborhood, but in general, there's an opportunity here as well. So let's take we know there's a lot of content, there's a lot of opportunities. Let's take a look at what it looks like for one patient. So a 12-year-old girl who at her well checkup, her mother reports that she's getting comments about being fat. Her BMI is 23, which is only at the 90th percentile for a 12-year-old girl, identified on the charts as being overweight. So what does the world look like for her? These are all the things that contribute, thinking back to the socio-ecological model, all the factors that contribute to her dietary patterns and her behavior patterns. Her current behavior is she skips breakfast. She eats a pretzel and juice for lunch. Doesn't really like the regular lunch. After school, she has a soda and snack food from the corner grocery store or Quickie Mart. Her dinner, her family eats out 3 times per week. They're too busy to cook. And at bedtime, she has a bowl of cereal while watching TV. If we look at her on the chart, then we notice that some of this is some parenting styles. Some of this is some of her personal preferences. Some of it is dictated by her schedule. If we look at what's going on in her environment, she skips breakfast because the school start time is hard for her. She eats a pretzel and juice because she doesn't like the school lunch and there are competitive foods there. After school, there's the corner store that's on her way home from school. They eat out because fast food is very available in her neighborhood. She eats cereal at night because there's a TV in her bedroom. So let's go back to her influences. And now we see these areas sort of impacting her weight status. The availability of foods in the house, the presence of a corner store with foods that are not best for her. Parent food preferences are factoring in. Accessibility of convenience foods and fast food is factoring into her weight status. Her school schedule is factoring into it. So all these things are factoring in. And this is why, I talk about the cocktail party discussion when people find out I do pediatric obesity. Because the comment that I get is, you'll get people say, oh, it's because we supersize. Oh, it's because kids don't get exercise anymore. Oh, it's because there's too much corn syrup out there. And my answer is, yes, it is all of those things. All of those things have an impact on her. And it's impossible if you're sitting in the clinic to think like, how the heck am I going to address all these things? But what we do is we go after them one at a time. And that's totally legitimate. If we look at her behavioral perspective, she doesn't want to go outside. She gets a lot of computer time. She prefers not to do homework at her study period. She doesn't know what to do on the weekends. Her extracurricular activity is cheerleading twice a week. So these areas are being affected. If we look at the environmental perspective on her behavior, on her physical activity, she has no gym due to school schedule. Neighborhood safety is an issue for her. family entertainment environment is not conducive to doing things other than screen time. Family scheduling is an issue. And so if we look at her then we've got these areas affecting her environment. And if we put it all together, we've got all these areas affecting her child weight status. So these kids really have the deck stacked against them. And what we're trying to do is we're trying to overcome this seemingly overwhelmingly daunting sort of challenge. This unbelievably busy slide further demonstrates, I don't intend for you to read any of this, but this is from the San Diego Healthy Weight Collaborative, their strategy mapping exercise to show the different areas where they're trying to affect pediatric obesity. And you see when you drill down in here, it's about these 6 areas. Now, obviously, you're not going to address all of these areas. But if you're a provider and you want to affect the healthy weight plan, here's something you can do. You can implement 5210 with families with goal setting in your office. Or if you want to affect, consistent messaging, if you're in primary care, you can do things like over here, like meeting with staff to talk about how you're doing messaging in your office. So there's lots of opportunities. It's a very complicated system. We're part of the answer, and it's important for us to play our part in it. What do we contribute to the discussion? I think it's really important to know that we can really play as a public health professional, as a nurse practitioner, as a physician assistant, as a dietitian, as a pediatrician, as a physical therapist. We can provide children's stories that really put a human face on the broader issues in our society that need to be addressed. We have access to community members. We have the ability to speak at different places. We can take advantage of that. Our story of what we're dealing with in our own offices is really important. They get bombarded, providers, community leaders get bombarded with statistics. It's personal stories and having a face put with a story that makes a difference. You can capture the attention of a lot of people if you're willing to put yourself out there and say things about this issue. We're uniquely qualified because we have credibility. Again, we have strong relationships. We have skill sets that other people do not have, and we have strength in numbers. For those of you who are members of the Kentucky chapter of the American Academy of Pediatrics, I hope you get the KACO messages that come out. That's Kentucky Action on Childhood Obesity. We're trying to create a bit of a groundswell of interested providers in the state. If you go to kyaap.org, you can still sign up for KACO even if you're not a member of the Kentucky chapter, and you'll hear about things that go on around the state. It's important to remember that as you go into community change, you need to fit it with your professional responsibilities. It doesn't require a ton of time necessarily. You have to prioritize what you're going to do, and it's important to partner with key stakeholders. Single steps really do make a difference. As someone said to me once about it's about a relationship with a significant other. It's not about vector. It's about vector, not velocity. It's what direction you're going in, not the speed at which you're traveling there. I'm going to skip through this part. This is about our efforts in Cincinnati and how we actually built a coalition of interested partners. We had a grand plan, didn't get funded for a while, and then the financial crisis hit, and we actually were able to get it funded through some ability to get some shovel-ready projects. So this is just a quick case study for you. You're a pediatrician in Moorhead, Kentucky. Sound familiar? On the same Saturday, you were asked to, one, talk to the local Mothers Club starting a 5210 campaign locally, asked to testify in Frankfurt on a bill requiring physical activity in schools, host a booth at a local school health fair on the importance of healthy eating, or for meeting with the city parks director about a planned bike trail. What would people pick of those? 2 or 4? I like 2 and 4. The other ones are great, and I don't mean to run them down. You're going to do those, and you can do those on other Saturdays. But if you've got a chance to testify on a bill in Frankfurt or to change your local environmental milieu, go for it. You want it. Your voice is really powerful. Your voice is very important. Health fairs are great. Talking to the local Mothers Club, they need to be supported. And sometimes those are quick, easy wins that are really good. But when you get an opportunity, go for it. As fellow Kentuckians, you guys, I think, will appreciate this story because you'll know the types of people that I was dealing with. I got asked to go to Frankfurt to testify on, the school physical forms that you fill out for your kids when they go into kindergarten and first grade and 6th grade. So you have to put down the height and weight measurement. Well, UK tracks for each of the school districts their BMI statistics based on those numbers that you report as measured in your office. So the school nurses were saying to us, we would like for the Kentucky chapter to support us in recording these so we can see if the interventions we're doing on a school basis are really making a difference. So they asked me to come down to testify in Frankfurt saying, yes, this is a good idea. Please let the nurses record this information into the charts, into the school district. De-identified, wasn't linked to particular patients. It seemed like a slam dunk. Already measured. The school nurses said it takes me 3 seconds to enter one of these. So I can get these all entered. I already have to enter it into UK's database. We can get tracking on Rowan County and look how we're doing compared to Menifee County. So they really wanted to do this. So I go down, I think this is going to be easy piece of cake. So I testifying in front of the Health and Human Services Board. Apparently this needed a state law to allow them to do this. And I have arrayed in front of me, like state legislators tend to have a little bit of inflated ability of like what they're legislating at times. I'm just wanting BMI numbers. And so I have one group that's saying, this is terrible. The schools don't have time to do this. You're putting more unfunded mandates on them. So that's on one side. And then I have the other side that's saying, this is personal data. I don't want personal information on here. I don't want, and honestly, there's like mental health data on these forms, but that is not de-identified. And this is de-identified. And they're saying, we don't want, people coming in here writing stuff down and saying that we're fat or we're this or that. So I had one gentleman from Western Kentucky, a pediatrician. So as I'm getting like slaughtered from both sides, getting attacked verbally, I had a general family practice doc from Western Kentucky said, Dr. Bolling, I'd like to thank you very much for coming down to Frankfurt and take time out of your busy schedule. And I'd like to say to my esteemed colleagues, just because people put this on a paper that says you're fat or you're a sissy, that's not going to make a difference. That's going to happen out on the playground. What we put on this form isn't going to say whether they're fat or a sissy. So I looked at him, I said, well, not exactly the way I would have said it, Congressman, but thank you very much. So we got it through, but anyway. So the issue is, there are lots of ways to get out there and make a difference as a healthcare provider. I would encourage you to do it. Small steps really do make a difference. So I know Steve is up next. I don't want to take time away from him, but anyway, my pleasure.